Welcome to Quality Pulse. If you're a healthcare professional, a hospital administrator, a student, or really anyone part of a quality improvement team, you already know that treating patients is, well, it's only half the battle. The other half, that's treating the healthcare system itself. Think about it. Fixing a broken healthcare process is incredibly similar to diagnosing a patient. I mean, you wouldn't just prescribe a treatment without first understanding the symptoms, mapping out the anatomy, diagnosing the root cause, and then tracking the patient's vital signs over time, right? Absolutely not. So today, in this explainer, we're going to apply that exact medical diagnostic metaphor to our healthcare systems using a pretty amazing set of quality improvement tools. So here's our roadmap for today. We'll start by defining healthcare quality. Then we'll map and assess risk. After that, we'll diagnose root causes, prioritize with Pareto, track our changes over time, and finally, bring it all together for the complete QI journey. Let's jump right in.
Section 1. Defining healthcare quality.
Okay, so according to the International Organization for Standardization, quality is the totality of properties of a service that determines its ability to meet anticipated needs. Now, it's really important to distinguish this from quality control. Quality control just measures the output, like checking if a manufactured pill is the correct weight at the end of the line. But in a clinical setting, we instead focus on quality improvement, or QI. And QI heavily emphasizes a no-blame framework. We aren't out here looking for who made a mistake. We're looking for systemic excellence. We have to acknowledge the problems in healthcare are almost always system problems rather than individual failures.
To actually measure these symptoms of quality from the patient's perspective, healthcare organizations often use the SERVQUAL method, specifically something called the Rater model. This breaks quality down into 5 areas: reliability, assurance, tangibles, empathy, and responsiveness. And in the real world, this is highly effective. For instance, there was a detailed study at the Sulawana Community Health Center in Indonesia, and they used these exact dimensions to evaluate outpatient services. They found that simply improving tangible physical evidence, ensuring reliable service, and fostering staff assurance directly boosted patient satisfaction and closed the overall quality gap.
Section 2. Mapping and assessing risk.
It is absolutely crucial to understand the stark contrast between quality assurance and quality improvement. Quality assurance is often reactive, right? It checks for compliance and, unfortunately, sometimes focuses on pointing fingers after an error has already happened. Quality improvement, on the other hand, is highly proactive. It's all about looking forward and fixing the process itself. To do this, QI teams map out workflows using simple flowcharts to spot bottlenecks, like in a patient's registration journey. They also use tools like a spaghetti diagram. This actually tracks physical movement, like a nurse's walking patterns on the floor or patient movement between departments, to identify wasted time and unnecessary motion. Once the process is mapped out, they apply a really powerful tool called Failure Modes and Effects Analysis, or FME.
So, take a look at how this FMEA from the Institute for Healthcare Improvement breaks down a medication dispensing process. For every single step, they ask, what could go wrong? That's your failure mode. Take the dispensing step, where the wrong medication might accidentally be pulled from a multi-dose vial. Then they score 3 things on a scale from 1 to 10: the severity of the harm, the likelihood it'll occur, and how hard it is to detect. You multiply those 3 numbers together, and boom, you get the risk profile number, or RPN. A high RPN, like the 300 we see for medications given prior to a pharmacist review, basically screams for immediate systemic intervention. It gives you this brilliant mathematical clarity on exactly where your system is most vulnerable. Section 3. Diagnosing root causes. Okay, let's see how we build our understanding using an Ishikawa, or a fishbone diagram. Let's say the problem is a delay in antibiotic administration. We don't just blame the nurse. Instead, we look at the equipment. Was an IV pump even available? We look at the methods. Are there unnecessary steps in the approval protocol? We look at the environment. Is the pharmacy totally understaffed today? Notice the major bones branching off the spine of the diagram here: people, process, equipment, environment, materials, and measurement. A fishbone diagram generates possibilities and maps out systemic vulnerabilities. It doesn't definitively prove causes, but it points us right toward them and away from single points of failure.
But how do you actually drill down into those possibilities once they're on the diagram? Well, you use the 5 whys technique. You start with a problem, say the patient received the wrong medication, and you literally just ask, why did this happen repeatedly? Why? Because the vials looked identical. Why? Because they were stored right next to each other. Why? Because the pharmacy storage protocol hasn't been updated. Why? Because there's no scheduled review process for the storage bins. You just keep drilling down until you hit a systemic cause that is specific enough for you to proactively test a change. It's so simple, but so incredibly effective.
Section 4. Prioritizing with Pareto.
Enter the Pareto principle, famously known as the 80-20 rule. In healthcare quality improvement, we frequently find that roughly 80% of a problem is caused by just 20% of the contributing factors. If you're a hospital administrator dealing with, say, hundreds of patient complaints or delayed discharges, identifying that vital 20% allows you to maximize your impact with limited resources. It tells you exactly where to focus your efforts for the absolute greatest return.
So, how do we actually get this data? We do it by using a simple, structured tool called a check sheet. This turns everyday observations into measurable information right on the floor, like tracking the specific types of medication errors or the exact reasons for a delay. Once we collect that data, we chart it. Look at this real data on surgical setup errors. An improvement team found 8 different types of errors happening, but they didn't try to fix all 8 at once. By charting the frequency, they discovered that just the top 3 errors, wrong supplier, excess count, and too few count, accounted for 75% of the entire problem. These are the vital few. By focusing their interventions exclusively on those 3 areas, they effectively eliminated the vast majority of surgical setup errors in one go.
Section 5. Tracking change over time.
Once we put an intervention in place, we have to monitor the system's vital signs. And to do that, we really must understand system variation. Now, hear me out. Not all variation is bad. Common cause variation is totally natural. It's just the expected day-to-day fluctuation in any hospital. Emergency department wait times, for example, will always vary slightly from a Tuesday to a Wednesday. But special cause variation? That's irregular. It arises from a very specific circumstance, maybe a sudden spike in infection rates, or, ideally, it's the direct result of your brilliant new quality improvement intervention. We need to know the difference so we can see if our changes are actually leading to real, sustained improvement.
And we distinguish between those 2 types of variation using run charts and control charts. A run chart is basically just a simple graph of your data over time, helping you visualize trends. But when you have 15 or more data points, you get to upgrade to a control chart. As the IHI Toolkit explains, a control chart adds upper and lower control limits. This is a game changer. If you're monitoring, let's say, laboratory turnaround times, these limits give you deep mathematical insight. You can confidently say, yep, this delay is just common cause variation, or nope, it just breached our upper control limit and represents a special cause alarm. It totally stops your team from overreacting to random noise and helps you ensure you are holding your gains for the long haul.
Section 6. The QI Journey.
We have covered an incredible amount of ground today, but let's bring it all together. Imagine emergency department wait times are increasing. A good QI team doesn't just guess at the solution, right? They start by using SERVQUAL to understand what patients are actually experiencing. They map the process and use spaghetti diagrams to find physical movement bottlenecks. Next, they use check sheets to gather data on delays and score those risks with FMEA. Then, they deploy a fishbone diagram and the 5 whys to diagnose the systemic root causes. From there, they use a Pareto chart to identify the major contributors so they know exactly where to focus their energy. Finally, they test a change and monitor the improvement using a control chart. It is a seamless, scientific journey from identifying a symptom to achieving a sustained cure.
Quality improvement is not about finding who failed. It is about understanding how systems work, identifying opportunities, testing solutions, and continuously improving care. So, I leave you with this. How will you use these tools to shape the future of healthcare quality? This has been QualityPulse, where we explore the ideas, people, and stories that continue to shape healthcare quality. Join us next time for another journey into the science and practice of quality improvement.